Thank you.
With that, we move on to the last but not the least topic for the today. I invite Dr. Sujoy Ghosh for the talk on today, which is serum testosterone, when and which one. Dr. Ghosh, I would request you to kindly load up your slides. And while we do that, let me introduce Dr. Ghosh. Dr. Ghosh is a well-known endocrinologist professor in Calcutta. He is also the author, editor-in-chief of the Southeast Asia book on Oxford Handbook. He is the executive, he's the joint secretary of RSSDI, as well as the secretary of Endocrine Society of India. And with that, I give the podium to Dr. Sujoy Ghosh. And the reason for this, setting the scene for this testosterone talk, is that, very often people get confused as to whether they should check total testosterone in clinical practice in India. We're not talking broad, we're talking India. Or should we test free testosterone? And at what stage of diabetic should the testosterone test be done? And how should one interpret that? Because the labs may not be NABL labs, and how to go about that. So on that note, I hand over the podium to Dr. Sujoy. Over to you, sir.
Thank you, Mithun. Thanks for your kind introduction. And I think I'm the odd man out in this session. With all the interesting talks, suddenly I'm going to talk about testosterone in diabetes, but I'll try and do justice to the topic that I've been given. And just a little bit about the background. If you look at hypogonadism in type 2 diabetes, it's suggested that, quite a significant proportion of people with type 2 diabetes might actually be hypogonadal. And whether we are talking about mild or overt. But one of the things that is to be noted is, in type 1 diabetes, when we see patients, especially the ones who are not obese, we rarely come across, or much less commonly come across, hypogonadism. So that could possibly kind of tell us that it's not necessarily the diabetes or the hyperglycemia which causes these alterations in the gonadal pathway, but probably it's the body mass index and possible associated insulin resistance, which actually is the reason why we have an association of hypogonadism in type 2 diabetes. And if you look at this particular slide, you can see when we are talking about individuals with or without diabetes, and if you look at the proportion of people with subnormal testosterone levels, it has a very, very strong correlation between your BMI and the levels of testosterone. So you will see that the more the BMI is, the more is the prevalence of at least subnormal free testosterone levels. And if you look at low testosterone and type 2 diabetes, I think this is a bidirectional relation, wherein if you have low testosterone, you're more likely to have problems of your glycemic control. And if you have hyperglycemia and type 2 diabetes and if you're obese, you're more likely to have low testosterone levels. So there was this meta-analysis which looked at if the total testosterone levels, if you checked, and if you found those who had total testosterone above 15.5 nanomoles per liter, they had a 42% lower risk of having diabetes as compared to those with levels lower than 15.5. And if you look at this particular Danish study that I've just quoted here, those who had low testosterone and low SHBG were strongly associated with the possibility of them having type 2 diabetes. The other thing which is quite interesting is low testosterone and its association with increased cardiovascular and all-cause mortality. Low testosterone in several of the studies have been shown to be associated with increase in all-cause and cardiovascular deaths. And in individuals who had low testosterone to start with, if you had an RCT to show that if they were able to reduce weight, particularly the obese ones, or if you gave them testosterone injections, then you found that there was a favorable change in the body composition with decrease in fat mass and increase in lean mass. There seems to be benefit in terms of cardiometabolic outcomes. The BLAST study is one such study of looking at about 850 odd diabetic patients with mild or severe hypogonadism, where they were treated with either injectable testosterone or with placebo. And what you can see is there is significant improvement in glycemic control with testosterone therapy, provided everything else was kept the same. And there was improvement in the BMI, it came down, lean body mass improved, waist circumferences went down, and overall sexual function and quality of life scores improved. So that's what I was trying to show you in the previous study, which has been shown here in this cartoon, that the A1Cs improve irrespective of what your baseline A1Cs are, particularly if your A1Cs were relatively higher off to start with. What about testosterone replacement on sexual function? Now, erectile dysfunction and sexual dysfunction, either in men or women, is actually multifactorial, with a significant proportion of it being psychological, or rather than having other issues. However, in type 2 diabetes, it could well be because of underlying macrovascular or microvascular disease, autonomic dysfunction, neuropathy, depression, and multiple medications that the individual usually is on. And falling testosterone levels significantly impact on erectile dysfunction, particularly when the testosterone levels are around 8 nanomoles per liter, where testosterone therapy might actually help individuals who fail phosphodiesterase inhibitors. Now, we've got to remember that the relationship between testosterone levels and sexual dysfunction is very, very dodgy and dicey. You might have a significant proportion of people with erectile dysfunction, arousal disorders, wherein the testosterone level might be absolutely fine, whereas you might have individuals with very low testosterone levels with no changes or no symptoms in terms of sexual function and erectile dysfunction. If you look at RCTs, it's quite clear that there might be benefits in terms of glucose lowering and HOMA, that's insulin resistance, and improvement in lean body mass and reduction of fat masses. However, changes in lipids seem non-significant. So by using testosterone therapy, it would seem intuitive that if low testosterone levels are associated with increased cardiovascular death, increased all-cause mortality, then testosterone therapy should actually improve everything. However, several studies have actually tried to refute that. We'll look at those studies, but first let us look at the possible mechanisms why testosterone therapy is not reducing risks of cardiovascular all-cause mortality in patients with type 2 diabetes. Mechanisms might be multiple, one of which is polycythemia, as the testosterone, once injected, gets converted to estradiol, which might stimulate erythropoiesis in the bone marrow. Testosterone directly stimulates erythropoietin synthesis in the kidneys, and increased dihydroxytestosterone levels might be associated with increased risk of fluid retention, thrombosis, and therefore increased risk of hypertension and heart failure. And high doses of testosterone might lead to alterations of HDL, lowering of that, and adiponectin. So if you look at the studies to look at the relationship between testosterone and cardiovascular disease, I think we've had a whole lot of studies, each with its own problems. We have very few good, well-designed randomized controlled trials. We do have some meta-analyses as well. So this is one of the studies which got published not too long ago, which looked at over 8,000 people with a baseline testosterone less than 10.4. And these individuals were randomized, and some of them got testosterone therapies. However, there was a significant number of people who had deaths, MIs, and strokes. And even after looking at 50 covariates, concluded that there was greater risk in testosterone therapy group. However, we were listening to Dr. Pratik Chaudhary in the previous lecture. This paper got challenged, and the authors revised the numbers and admitted that there was a problem with the data. And in another study, analyzing prescribing data in men treated with testosterone, which actually looked at non-fatal coronary events as the major endpoint. And this evaluated 12 months before and 3 months after therapy, and there was no benefit. Now, if you're actually trying to look at benefits from testosterone therapy, we probably need a longer duration study to tell us whether there was anything happening in terms of positive outcomes. So there are studies suggesting reduction in CV outcomes as well. This is one of those studies in a prospective study of over 800 people who were randomized to either testosterone or placebo. it was shown that testosterone therapy and the use of phosphodiesterase inhibitors was independently associated with reduced all-cause mortality. This is that particular study which looked at individuals with low testosterone, what happened to them if you treated them with three options, that is testosterone, phosphodiesterase inhibitors, and statins, and you can see that there is significant benefit. Now, when we are talking about hypogonadism in type 2 diabetes, what could be the possible mechanisms? One of the things that I've shown you before during the talk is that it's possibly the obesity and the BMI, which is probably the major reason for increased inflammation, alteration in the central pathway of the GnRH trigger pathway, leading to decrease in LH and FSH. And when you lose too much of weight, you can have hypogonadotrophic hypogonadism. Similarly, if you put on too much of weight, you can have hypogonadotrophic hypogonadism. So that's the basic pathophysiological mechanisms and the background. But in a given patient, when should you test? So should you be testing all your type 2 diabetic individuals to figure out if they have low testosterone levels, all the males? Is it really going to be cost effective? So let us look at the recommendations of the wise people. If you look at the ADA guidelines, it clearly says in men with diabetes who have symptoms or signs of hypogonadism, there you can probably think of testing. And a morning total testosterone is what we should be testing at that point of time. In men who have total testosterone levels close to the lower limit, it's probably reasonable to check the SHBG. I'll talk about that a little later, as it's often low in diabetes and associated low testosterone levels. LH and FSH, usually you would do only when you're trying to determine whether this is primary or secondary hypogonadotrophic hypogonadism. In a clinic, you would normally examine the patient, and the feel of the testis in most of the situations will tell you whether this is primary or secondary hypogonadism. If you look at the Endocrine Society guideline, the suggestion is not to treat asymptomatic people in type 2 diabetes. The reason being that we are still not very sure that if the testosterone levels are low and if the individual has got no symptoms, that in such a situation that there is any extra benefit of treatment, given the fact that we are still very unsure, number one, about the possible long-term risks of therapy, of course the costs, and the costs of monitoring and administration of the drug. If you look at the RSSDI ESI clinical practice recommendations that got published in January of this year, it talks about doing the test if you have symptoms of hypogonadism, and it talks about testosterone replacement therapy. I think Mithun was part of this group, may be beneficial in men with diabetes with symptomatic hypogonadism. So this is just a table which from an article of Dr. Shailendra Vasin to tell you about, again, about what are the symptoms and signs of hypogonadism and possible low testosterone levels. I'm not going to bore you with that. But one of the things that you could probably look at is in our type 2 diabetic individuals, it's probably the ones with infertility, maybe osteoporosis, low trauma fractures, and of course, sexual dysfunction, low libido and erectile dysfunction. That's probably where you're justified in doing a testosterone test. Now that you've decided whom to test, and now that we've talked about whom to treat, and the fact that we've talked about the pathophysiology and the mechanisms and the problems, comes the next big question is what test to do. Now, as Mithun said, we are talking about an Indian scenario. So again, if you look at that, what do we talk about when we say total testosterone? When we say total testosterone, we are trying to talk about the unbound or the free testosterone and the protein-bound testosterone, both clubbed together. And what does testosterone normally bind to? The most important two fractions that it binds to is the SHBG and albumin, and to a very smaller extent, the cortisol binding globulin and orosomucoid, it also binds to. And when we talk about bioavailable testosterone, what do we mean? We are talking about the unbound testosterone, and we are also talking about the testosterone that's bound to albumin, because that's relatively a soft binding which can easily be dissociated and be delivered at the level of the tissue. The free hormone hypothesis clearly kind of tells us that it's the free hormone which binds at the level of the tissue receptor is the one that's important for biological functions. And free testosterone should probably in the Western world be measured in conditions where you think that the SHBG levels are going to be abnormal. And I'll talk a little bit later about what are these conditions that can falsely lower or raise SHBG levels. And clinicians could probably think of measuring free testosterone levels in individuals where values are slightly above or lower than what the normal levels are. So if in our scenario we think of conditions that decrease serum hormone binding globulin, the two commonest problems that we face usually is obesity and type 2 diabetes. There are certain drugs, hypothyroidism, acromegaly are relatively easier to pick up, and conditions that increase SHBG, the most important of them is aging. So particularly because you're looking at a problem in type 2 diabetes in a possibly aging population, think of these possible reasons why the serum hormone binding globulin might be altered. Now, total testosterone measured by RIA, chemiluminescent assay, or chromatography or tandem mass spectrometer. At my center, we use a chemiluminescent assay, and you've got to remember that there is considerable inter-assay and inter-laboratory variability in the total testosterone measurement. And ideally, you would want a liquid chromatography mass spectroscopy for testosterone measurements. Unfortunately, most of us do not have access to LCMS, except from some of the private labs who claim that they use the LCMS. The other major problem is, when do you measure testosterone? Because most of the times that I see people coming with a low testosterone value is because the patient has been to some clinic, and then at the end of the clinic, the doctor has prescribed a few tests, and at 2 p.m., the patient has had a testosterone level measured that's low and has come back to me as an endocrinologist for consultation. So again, re-emphasizing the fact that if you're going to do a testosterone test, whether it's a total or free, we are going to talk about that later, please do it at around 8 to 9 a.m. in the morning, because that's when the peak values are supposed to be. If the values then are still lower than what you expect it to be, only then think of that there is a problem. If you're looking at the LH and FSH at that point of time, please do a 3-pooled sample, 3 samples taken 20 minutes apart, pool it and then do it, because there are variations of that. And you know that glucose and food intake suppresses testosterone concentrations. So when we are talking about doing the test, please do it in the morning in a fasting state. And it's always important to confirm low testosterone levels, because 30% of men with an initial testosterone concentration in the hypogonadal range will have a normal testosterone level. So most of the time, the values that we see as low, and we jump into the conclusion that these guys have got a low testosterone, most of them will come back with a normal test report. Only a small fraction of healthy young men have a testosterone concentration below the normal range during a 24-hour period. So I would recommend doing 2 tests in the proper time, in the proper manner that I've already talked about. So free testosterone, if you're actually measuring, should be measured using an equilibrium dialysis method. Again, that's something which is not available. So if equilibrium dialysis is not available for measuring free testosterone can be derived using formulas. Again, that has its own limitations. I'll talk about that in the next slide. The estimates of free testosterone, regardless of formula used, are predicted upon accurate measurements of total testosterone, SHBG, and albumin. Free testosterone measurements by direct tracer analog immunoassays are frequently available. You'll find a lot of the labs doing these tests. Please don't do these tests. So that's the online calculator. You just calculate the total testosterone that you've measured, the SHBG and the albumin, and then you can calculate it. But like I said, it's rarely ever do I do a free testosterone. I would do a total testosterone. If required, repeat the testosterone. If required, check the SHBG. If required, check the albumin. But rarely do a free testosterone. That's a complicated formula that tells you how it is done. And like I said, LH and FSH might be estimated if you're wanting to figure out this is primary versus secondary hypogonadism. I shall stop there, Mithun, for questions.
Joyda. That was a topic really well covered, and the controversies coming out very nicely. So, one take home message, what Sujoyda is saying, and what I would agree, please do not test for free testosterone. I think that is a take home message that should be there. If you have to test it, if you feel inclined for clinical suspicion, do total testosterone with SHBG and albumin and calculate that. Now, Sujoyda, most of these, when we talk about testing or the reasons for testing for testosterone, they mention if the signs and symptoms of hypogonadism are there, and in that they say sexual desire and activity or less libido. But how often is that asked in a diabetes clinic when we are actually seeing patients? And most of the studies that are done with diabetic and testosterone replacement, like the Times Square study or the BLAST study, showed an improvement of around a 1% of HbA1c, which is very similar to oral anti-diabetic medications showing it. So are we missing a point and denying people by not asking questions in the diabetic clinic?
Right. To answer that, I think some of the clinics, at least that I know of, what they do is when your patient is sitting in the waiting room, you have a couple of questionnaires for them. And probably in case of your male patients, there are 2 questionnaires which they should probably be filling in. And I'm guilty that I still haven't managed to start that in my clinic. One is for the sexual dysfunction, the FSFI you can fill in. And the second is a questionnaire for OSA. I think obstructive sleep apnea and sexual dysfunction are 2 things in a day-to-day clinical practice in the busy diabetes clinic we are missing. I don't know whether Mithun will agree with that, but I think these 2 are something that at least the patient can fill in even before he comes into your room. So if we were filling in that questionnaire, we would probably be more aware of the problem. And then in terms of the glucose lowering that you're talking about, I'm not very sure for the people that I've used testosterone. It's just a gut feeling. I don't have data to either refute or support it. I don't think the glucose level goes down that much with testosterone replacement therapy. What happens is most of these people who are actually on these therapies, they are much, much more motivated to actually, lose the weight and lifestyle measures. Because if you tell them if you lose weight, your sexual function is going to improve, I think they are much more motivated to change lifestyle. That's my gut feeling.
Okay.
We can't see you, Mithun. You need to turn on your camera.
Yeah, sorry. So,
Sujoy, just to share with you, we had one unpublished data on overall prevalence of hypogonadotrophic hypogonadism in type 2 diabetes. We tried to correlate it with the Adams score and ultimately found that close to 36% of type 2 diabetes, they have HH and ED being contributed by HH itself.
Right.
It is yet to be published. That was one of our DNB thesis over almost 200 patients. And
so my experience on that.
Can I just interrupt? Because I would probably think a little bit same, because one of our DM trainees did a project like that. I think because and for example, you are a specialist, we are seeing referral patients. We are seeing people with established microvascular disease. We are seeing people with established macrovascular disease. We are seeing not new patients. We are seeing people who've gone around, with so many people. So I have a gut feeling a primary care physician level study would probably give us a better idea.
That is,
and we would probably overestimate it, because if I replicated that in my, say, corporate practice clinic, I think we will get bigger numbers.
Higher number. Yeah. We got it 36%, which was quite on the higher side. Maybe that is the reason.
Yeah. Sujoy, unfortunately or fortunately, I was also one of the co-author of the BLAST trial, and we showed that the metabolic benefits takes a bit of time to come in. It doesn't come in so early. It comes in around 9 months to a year to see metabolic benefits on glycemia.
I think I'm trying to mention that as a criticism for another paper which tried to show that there was no benefit in terms of cardiovascular disease, because it was a shorter term study. So we need to give it time for the metabolic benefits to happen.
Fair enough. I think there's a question for you, Sujoy. Should we do testosterone? This by Dr. Tosib Nabi. Should we do testosterone in diabetic patient when they have good glycemic control?
I think the glycemic control bit is important because, like I think I was trying to show, that one of the mechanisms through which we have hypogonadotrophic hypogonadism in diabetes is through the GnRH pathway. Now, anybody who's either obese, has sleep apnea, has poor glycemic control, there might be alteration in the GnRH pathway. So maybe doing the test at the time when the glucose control is better will probably give lower false positives. But the fact that somebody is well controlled, I'm going to go and do a test, that's not the message that I would like to give. If you are well controlled, you're still having problems, you have a trigger of symptoms. Because, why are you going to test? Because what we have found out from studies is that the benefit is there only if you have symptoms. For the asymptomatic ones, we don't have any documented benefit of testosterone therapy. On the other hand, we are worried about the possible side effects, the costs, and the costs of following up the patient. So therefore, if an individual has symptoms, yes, go ahead and do it. With the precautions that I've talked about, when to do it, how to do it, and what test to do it. Because most of the errors happen there in terms of when to do it, how to do it, and what to do.
There's another question for you. Is there a real link between testosterone levels and COVID-19 infection?
Don't know. There are a couple of anecdotal association studies that have been published already in the public domain, talking about testosterone and COVID. People being bald, being told as a risk factor for COVID, and with regard and several postulated mechanisms as well. I think with COVID we've all gone overboard, and I think the standards of peer review, the standards of strictness of publication has actually gone down in terms of COVID. Anybody and everybody can get anything published on COVID right now.
And the other thing which I do in clinical practice, and I don't know what your opinion is before testing, I tell the patient it's like hypothyroidism. If the levels are low and we are committing for a treatment. And that often, because many of times you see people actually treating with testosterone replacements. I get referrals treated for 3 months and 6 months, and that actually spoils up the whole axis. Rather than first the treatment was wrong, and secondly the whole axis is screwed up very nicely. So should testosterone replacement, I think, should be reserved for specialists rather than.
I would think so. I would think so.
Shall I request all the panelists, all the speakers to kindly come on the video? Pratik, Rajiv sir, Sanjay sir. Pratik, there was a question, there is a mention by Dr. Sujoy about pool sample of LH and FSH. What's your experience on that? Because I traditionally never did that in England.
No. Pool, sorry, say that again. On which sample?
So pool sample of LH and FSH. And prolactin as well? Do you do prolactin as well?
No.
LH and FSH, he takes 3 samples, put them up, and then divides and takes an average out of the whole thing to guide whether it's
that's certainly not standard practice in many of the places that I've worked in. So you'd have you do a lot of dynamic testing, of course, in people where you've got suspected problems, but no. And for prolactin, we do a lot of cannulated prolactins, where you don't take a standard sample, you leave the cannula in, and you might take a cannulated sample for prolactin. But no, I don't think that's.
The concept is essentially that the LH levels, it comes in spurts.
It does, yeah. You got.
So conventionally, at least in our center, what we've been following is that because the spurt happens every 20 minutes or so, 20-30 minutes. So if you take 3 samples and you pool the serum and then do a test, you get a better idea only in the ones where you're suspecting hypogonadotrophic hypogonadism. If you're suspecting hypergonadotrophic hypogonadism, it does not matter at all. Because of the fact that in type 2 diabetes, when we are suspecting hypogonadism, it's predominantly hypogonadotrophic hypogonadism. So if you get a dodgy kind of a result where you're not very sure, is this LH lowish? So we would do that.
Okay. Thank you so much. I see there are no further questions. Dharmendra, you want to ask something?
Just to carry forward this question, as you asked for pool sample, just regarding prolactin level, did you ever encounter or do you believe that doing prolactin sampling from the dilution will help sometimes to detect hyperprolactinemia? Or because many a times lab error comes, and when we advise diluted sample, we come to know it's not 300,000, it's 30,000 or more. So what's your opinion on that?
So I would talk about, the clinical background against which I'm sending the sample. When you're suspecting that there's going to be a high dose hook effect, that's when I would think of doing a dilution. Otherwise, if the background doesn't tell me anything about the patient that this is going to be possible hook effect, I wouldn't do that. That's number one. Number two, if the results has come as greater than normal, whatever your upper limit of your assay method is, I would probably be tempted to do that there, because if it says more than 150, is it 1500? Is it 15? Is it 3000 or something like that? Because when I'm again trying to treat this individual and follow this individual up from maybe a macroprolactinoma, I can probably even tell the patient, it was 15,000, it's come down to 10,000, then 5,000, because it does take time to come down as well. So these would probably be the two areas where I would go for a dilution, where I suspect a hook effect, and secondly, where, the more than upper limit of your measurable limit has been crossed, just to make sure, when I'm following up the patient, am I going to up titrate the dose of cabergoline or not? Looking at this, because if it was 1600 and it's now come down to 1400, there's a difference between something which was 3000 and has come down to, say, still more than 1500, because subsequently, when you're following up a macroprolactinoma, if you had not done that dilution, the patient will come up and say, even last time it was above X, even now it's above X. So has it actually changed?
Yeah.
Okay, thank you. Dharminder, if there are no further questions, we can close the session and thank our speakers.
Yeah, I think there are no more questions. So would just would like to thank you, Dr. Mithun, first of all, for moderating this session very nicely, making it more interactive, and also my bottom of heart thanks to our speakers for making the session very interesting. We are getting the reviews from YouTube also that people are really, really enjoying the session. And thanks you all. So here for now, we are just logging out and we are stopping the session. And next session, we are starting at 5 p.m. in this theater. Yeah.
Thank you.
Thanks a lot.
Great talk, Dr. Pratik. Great
Thank
talk.
you. I enjoyed it as well. Thank you. Good to
Thank
see you.
you.
Bye, everyone.
Yes, sir.
अभी कोई ज्वाइन हुआ है क्या?
So not from speakers, so we are just sending the message and calling them.
पहला स्पीकर कौन है?
First is Juliana, Dr. Juliana Chan.
उसका बायोडाटा है ना तेरे पास?
हाँ है मेरे पास.
तो तू डिस्प्ले करेगा एंड देन आई विल टॉक. कोविड पे है ना बेसिकली.
हाँ, कोविड पे. Do you want me to send all the biodata on your phone, sir?
Yeah, send it to me, not this phone, my regular phone, 98201.
Yes, that one. Yeah. Sure.
टाइम છે ને? We have time.
Yes, 15 minutes.